Okay, so I think we are ready to start. Welcome everyone. So I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease, as Educational and Patient Program Manager. And it's my great pleasure to welcome all of you of this first session of comprehensive program address tackling aplastic anemia and PNH for patients and their family, named EuroBloodNet Topic on Focus. And this program has been coordinated indeed in collaboration with Patients Association for guaranteeing really a patient-centric approach to this educational program. And so I would like to thank the PNH Support, the PNH Global Alliance. PNH Support is focused on PNH and is represented by our ePAG, Maria Piggin. And also I would like to thank Lichterzellen, sorry for my pronunciation, that is a patients association focused on aplastic anemia and PNH and has been represented by Pascale Burmester, and also, of course, EURORDIS. So these programs, as you can see, or as you have seen, it's a cycle of 9 sessions that will be held once per month. And it aims to disseminate very topical areas related to aplastic anemia and PNH among the patients community, because we would like to give visibility to medical services available in Europe, present quality of life, cutting edge, advancing in this field of this rare condition, or even very rare as for PNH. And of course, we are going to talk also about treatment option. Today, we are going to assist to this lecture on understanding aplastic anemia. With us, we have a duo asset of patient representative and healthcare professional. So I'm very pleased to introduce this outstanding speaker. So Professor Beatrice Drexler. She's an attending physician at the hematology department at the University Hospital in Basel in Switzerland. She's responsible for the post-transplanted bone marrow failure outpatients, and also her research focuses on the clinical aspect of bone marrow failure syndrome and PNH. She's also very active and member of the Severe Aplastic Anemia Working Party at the APMT. And the duo, so we have also a patient representative. So we have with us Miss Isabelle Flageul, who suffered from multiple sclerosis since 2004. And then she contracted idiopathic aplastic anemia in 2012 and spent 6 weeks in steroid chamber. Isabelle has completely recovered, and he's working part-time on the company, the CRS project, and she's also involved in the French association HPN France Aplastic Anemia to raise awareness, support research, connect and help and defend the right of patients and their family. So I'm very pleased to pass the floor first to Professor Beatrice Drexler and then to Isabelle. Thank you very much.
Thank you very much for this kind introduction. It was a very kind introduction. I do have to admit, I'm not a professor. Maybe someday, we'll see. But anyways, I see a lot of patients, and that's, I think, is why I'm here. And this is a session we focused on patients, and we discussed this before and decided that I will start with a small presentation first. It will only be about 10 to 15 minutes, covering the basics of aplastic anemia. I wanted to let it be basic because I think we can discuss details then further on in the discussion, and I don't want to overdo it with scientific details. So that's why we stick to those 10 to 15 minutes. And then Isabelle will ask several prepared questions, and I think we can take it from there. So I have nothing to declare for this webinar. So when we talk about aplastic anemia, and most likely many of you who attend have heard about this disease before, or either affected or family members affected, or you have any kind of connection to this disease, but still I wanted to make a little bit of an introduction. What is aplastic anemia? Because aplastic anemia by name actually is, some would think it only is anemia, but in fact it covers the whole blood system, which means that 3 cell lines are affected. So you have a low count of red blood cells, they're called erythrocytes here. You have usually a low blood count of neutrophils, and you have a low count of platelets. So usually you have a 3 lineage cytopenia, as we call it. Some patients have a B lineage, but at least that is what you have or should have by definition. So it is not only anemia, it affects 3 cell lines, and the consequences arise out of that. And I put a little bit of an image next to this tree to show what happens in the bone marrow. So when you don't have those cells in the bone marrow, it looks really empty. So this is an actual real slide. On the left-hand side, you can see a healthy bone marrow. It has some spots in between where also no blood cells are, but that's actually fat. And on the right-hand side, you see an empty bone marrow. And I think everybody can understand what that means. So you're missing on blood cells. And so you have not enough blood, very simply spoken. Now, if we talk about aplastic anemia, you should always distinguish 2 types of aplastic anemia. On one hand, you have the so-called acquired aplastic anemia, and that's usually immune-mediated. And on the other hand, you have the inherited bone marrow failures. And I think because of time reasons, we will not touch upon this too extensively, because it's a huge group of syndromes. Most likely many of new syndromes will be discovered in the near future. So it is an exploding field and many things to learn, but for now, it's too complicated and has a very diverse characteristics. So I would stick to acquired aplastic anemia for this session. And acquired aplastic anemia, as I show you on the picture, usually is thought to be caused by actually T cells. So T cells are some kind of immune cells we have in the body, and those actually attack our blood stem cells. And by that, the body is not able anymore to produce red blood cells, platelets, and neutrophils. And that causes then the 3 lineage or B lineage cytopenia. Back in the days, there has been acquired aplastic anemia by toxic reasons, for example, if you had radiation or chemo. But nowadays, by definition, this is somehow not used anymore for the term acquired aplastic anemia. But it was usually originally used. For example, also some antibiotics who caused aplastic anemia, but it seems to be that, or it is for sure, a different pathogenesis. And then there's a very rare form of acquired aplastic anemia. It's the so-called post-hepatitis aplastic anemia, where it's caused by some kind of inflammation, and it's also a different story by itself. So these 2 groups cover the definition of aplastic anemia and should be differentiated not only by its characteristics, but also by therapy later on. I just want to recall, because some of you might be a little bit confused or want to know what is inherited bone marrow failure. So maybe some of you know Fanconi, for example. There's a big patient group on that as well. Some of you might know the term dyskeratosis congenita. It's also a form of inherited bone marrow failure. And some of you might know, for example, Diamond-Blackfan anemia or Schwachmann-Diamond. These are ribosomopathies. And then there are, as I said, many, many more. Now, I want to also cover, of course, the clinical symptoms And as I said, since the red blood cells are affected, the patients have anemia, and that causes a variety of symptoms. Two I've mentioned here, for example, fatigue and dizziness, but there are many more, and we most likely will talk about those in detail. Because we have, the patients have less neutrophils, patients are prone to infection. Infection actually is the main cause of mortality. So that is the most risky blood parameter, and it is the most actually important to monitor and to treat on time. And then there's thrombocytopenia, which means there's not enough platelets, and that's why patients then bleed. Bleeding has been also a major cause of mortality, but as you might know, you can actually transfuse platelets. So that's actually, it's why it's easier to treat in an urgent manner. Now, those three big, let's say, symptoms, for example, bleeding, anemia, and infection, are always mentioned when you talk about aplastic anemia, but I think it's very important also in this session and for the patients to talk in between and even on a very broader scale about aplastic anemia symptoms, because it's not covered only by those three major symptoms. It has a huge impact on many, many other physical functions of the body, and of course also psychological issues. And to cover this more in detail, there were colleagues from Aachen, Germany, but also my group tried to characterize those symptoms more in detail, because many of those were actually not known, and even are not known, I think, today, or at least not nicely summarized in the literature. Is that you can have a lot of more symptoms. And what we tried and what the Aachen group tried is to develop a questionnaire where you can actually assess those symptoms. I think this is very important, since actually till now in huge clinical trials, only questionnaires are used for cancer patients. So cancer questionnaires are actually used right now for PNH trials, but also for aplastic anemia trials. And I think that's can cover some of those symptoms which are not known yet, but not all of them. And that's why we tried to really design a disease-specific questionnaire. However, I must admit, I mean, this is just the beginning. I think we really have to work on that because I think it is important for the patients long-term to really understand what symptoms they have, and then to actually help patients regarding those symptoms. And I can show you on the left-hand side a little bit of information we have, at least from one trial, which was published in Leukemia, where you can see the authors not focused on the classical symptoms, but they show also that it has a huge impact, for instance, on social functioning, on role emotional functioning, on mental health. So I think many aspects we are not concentrating too much on, and maybe especially from a physician side, I'm critical on my colleagues. I'm not sure if the time always is enough to really assess this in detail, understand what is happening there. So when we really want to talk about the next step then, and you made the diagnosis of aplastic anemia, you have to, of course, decide on treatment. And when you look at treatment, I think it's very interesting to look at the history of that, because in the 70s, actually, you didn't have too much of treatment for those patients. It was, in fact, in many cases, if you at least had a very severe or severe aplastic anemia, I'm not covering on those definitions because I think it's way too much for now. But if you have a very severe case of aplastic anemia, the chances with just no therapy back in the days was actually not really high. So it was, in most cases, a fatal disease. And that changed massively up to now. The next step was actually to introduce supportive treatment in the 70s. And that what means supportive treatment, that's transfusion and maybe antibiotic and things like that. And you can see actually that by that survival could be improved. The huge big step which could be achieved actually was start in the 70s, but in most centers in the 80s then, when they introduced ATG. So ATG is an anti-tumor globulin which actually attacks then or is focused on the lymphocytes. So you actually try to eliminate lymphocytes out of the system because you think that those lymphocytes attack the stem cells, right? So that was shown to be a very effective treatment, and you could rescue many patients by that. You could even further improve outcome when you added cyclosporin to ATG. As you can see here, cyclosporin has a huge effect, but as you might know, cyclosporin in some patients can never be stopped. So many patients need a so-called maintenance therapy for cyclosporin. So they are on cyclosporin for the rest of their life. I think that's a very important point because cyclosporin, and I also work with transplant patients, is a nice treatment. I mean, it's really effective, but it has a lot of side effects. And that's something which is a huge burden for the patients. And unfortunately, still patients need a long-term therapy with this agent. And there hasn't been too much of improvement on that. Maybe at some point we have new agents who might be also, or can we substitute cyclosporin, but for now, cyclosporin is the standard for this care. Now, in the very recent past, there was a huge new step since we didn't have any changes for the last decades. I think it was a huge success actually, and it was published prominently in the New England Journal this year that Eltrombopag is a new agent which actually can even further improve treatment first line with ATG and cyclosporin. And the important effect of Eltrombopag is actually that you have a faster response. So usually back in the days, if you gave ATG and cyclosporin, you had to wait for weeks and months till the patient responded and they were still prone to infection and they needed transfusion. And that was a risky time for many patients, very difficult time actually, because they had to come to the hospital many, many times and they were still really at risk. But the huge advantage of Eltrombopag actually is that you can speed up this time. And by that, patients have less transfusion, they have most likely less infection. So I think it's a very important step. However, you have to keep in mind that when you look at the data, for now at least, when you stop Eltrombopag, patients actually also relapse. So it is not a complete game changer. I think it's a game changer for the beginning of the treatment, but later on, I think there's still a huge need for further therapies. And this is data now only from first line. I'm not talking about relapse setting now. I'm not talking about refractory cases because that's something we don't have time for. But I think it's a huge success. And the NIH from the US and now also the European group showed the efficacy. Now, I talked a lot about immunosuppressive treatment, which is a treatment for many patients. But of course, as you know, the big other treatment for patients with aplastic anemia is actually transplantation. And the reason for that is that we know, and that's the slide, the image on the left-hand side, is that actually if you're a young patient, the outcome is better if you are transplanted. And the transplantation outcome is highly dependent on your donor. So if you have an HLA identical sibling, nowadays even more. The outcome is really good. It's about, let's say, 80 to 90% for the young patients. And that's the reason why patients who are young and fit, usually transplantation is recommended as a first-line treatment. We can talk a lot about the age cutoff to use this, but many experts say about 40 is the cutoff. So under 40, you should recommend transplant. Over 40, you should recommend first-line immunosuppressive treatment, as I said, with ATG and cyclosporin and trombopac. In some patients, you don't have an HLA identical sibling, and you only have a matched unrelated donor, or you don't even have any donor, or maybe you only have like an alternative donor, for example, like an haploidentical or a cohort or something like that. So up to now, we don't have the data yet that those donors are be associated with the same outcome. Actually, they have a worse outcome than we know from the HLA identical sibling donors. So for now, this standard is not changed. But I think there is many things coming up now, because, like, as you can see on the right-hand side, actually the outcome with haploidentical donors seems to be very good. For now, we only have small data set of patients, for example, from the US. In Baltimore, they actually tried this out first. But as you can see here, they have patients where they have the 100% or in the relapse setting, which is incredible. But it's a very small cohort. And in the first line setting, they had like 86% overall survival. So that's impressive. But I have to say, this is a small cohort, single center. We have to see how it works out if you do it in the multi-center and real world setting. So taking together, if you look at acquired aplastic anemia, and that's what I tried to cover in this little session, is that the standard of care, if you have the diagnosis, is really based on your age and your comorbidities and your fitness. And if you're young and fit and you have an HL identical sibling donor, you go for transplant, and that's the recommendation, at least. If you're older, and then first line treatment is HTG right now with cyclosporin and trombopac. And if you're in between, it really depends on your, let's say, fitness and on the recommendation of your physician, and you have to decide on the disadvantage and advantages. When we talk about then relapse therapy, I think that the field is completely open, and I could talk then many minutes more, but I think for now, I think we leave it like that, because I think it gives you a little bit of an overview. And I think right now we would want to cover the patient side. So I give the floor to Isabelle. And I'm very happy to hear her questions, and then I think we can discuss it very nicely.
Thank you very much, Beatrice and Maria Angela. It was really interesting, all that you have been explaining. This comes with the idea, the patient idea, because I tried to recall when I was sick about 10 years ago. And the first questions I had at that moment, before knowing exactly the disease I was having, I was facing, was to know why I was so pale, why I was breathing easily, and why when I was bleeding, I couldn't stop the blood. And the last thing is that why I had so many bloody stitches on my legs. It was enormous. And from what I understand, if you can confirm, I think this was really linked to the first symptom of the disease.
Of the what is your last?
Of the disease. Of the
disease. Yeah, definitely. Yeah. It was caused by the severe cytopenias. So
okay.
Anemia and thrombocytopenia. This described your symptoms very nicely. Yeah.
Yeah, and then I entered the hospital, and the doctors announced me the aplastic anemia. And I was wondering, okay, what did I do? Why do I get it? Do you have a medical reason for that? Are there some specific patients that can get it? Can anybody get it? Do you have some reasons?
Yeah, very good question. I think I can cover it maybe in a small scale. I think it's something we don't fully understand yet. What we do know, it's a form of an autoimmune disease, right? Because you have the immune system which attacks, as I can hear right now, hopefully you don't hear too much my children who attack something in my house. But anyways, the immune system attacks the stem cells, and it is a form of autoimmune disease. So what we know actually, and that fits to your story very well, is that some patients actually have other autoimmune disease. For example, multiple sclerosis, for example, thyroid disease, for example, some kind of rheumatoid disease. That's a very well-known association. So, and that has most likely to do with your genetic background, because we know that some genes are important, or at least make you at a higher risk to develop autoimmune disease. And there are other experts who will tell you which gene is affected and so on. That's not my specialty, but we see it in many patients, this association. So actually what I can tell all of you is that nobody has done anything wrong, or has, I don't know, had the wrong diet, or moved wrong, or I don't know, anything what patients sometimes think they actually caused their disease is not true for acquired aplastic anemia. It's more true, of course, for cancer patients, for smoking and bad diet and stuff like that. But for acquired aplastic anemia, this is not the case.
Thank you very much. And I can confirm that because I have a multiple sclerosis, and I after that got the aplastic anemia. And the doctors that were taking care of me, they tried to find the link in between the two diseases. Mm-hmm. And they told me, okay, there is no link. There is no explanation. We cannot tell you that if it's because of your multiple sclerosis that you have the aplastic anemia. Mm. And so that was something that I was happy about and unhappy, because I was thinking, okay, perhaps there could be an explanation of that. But what has been discovered is that I think we are 10 patients around the world, 10 declared patients having both disease around the world. And then I entered the hospital, and as Maria Angela was saying, I stayed 6 weeks in sterile room. And I was asking myself, because it's the moment you have time to think. You have not a lot to do, you're not allowed to go out, so you think. And I was wondering, why is it considered to be a chronic disease? And what impact does this have on my life? What do I have to do from now differently from what I was doing before? Are there some restrictions? Are there some things I can eat, I cannot eat? Just to know if there are.
Yeah, that's a very good question. So actually, I just had this discussion today with a aplastic anemia patient, because she was 6 months after ATG. And of course, she asked me, can I go on a flight again? And can I see many people again? And how do you think on that? And I think this actually also illustrates quite nicely the term chronic disease. Now, why is it called a chronic disease? Because at least some patients actually are affected by this disease lifelong. We know that some patients actually recover. They show a complete remission after first-line treatment, and then they stay in a complete remission for the rest of their life. I can say this at least for the Basel cohort in Switzerland, because my chief, and that was my starting point for this disease, was he sent me to all the files of aplastic anemia patients, which we had treated in Basel since 1974. It was 300. And I had to look up the remission in every patient, and then I had to look at the survivor and outcome of all those patients. And it was very interesting to see that all those patients, at least most of those patients who achieved complete remission, they had a almost normal life expectancy. I did not cover in this study like quality of life issues, because I think that's something different. Because if we think about transplant patients, we know they will for sure have quality of life impairment in many patients for the rest of their life, even if they're in complete remission. So it still marks the chronic style. But there are some patients with only treated immunosuppressive treatment, and they have a very decent life, right? But this is only like not small percentage, but it's only a fraction of patients. So you also have patients who respond to treatment, but they still need those what I call maintenance treatment. So they still show some kind of relapse signs or a full relapse, and you have to restart treatment again, and they were treated the rest of their life, and that has a huge impact on your life quality, and also you still most likely have symptoms, and of course side effects of the treatment, and many parts of your life. So that's something where the disease just never stops, and then you have those patients who have a very difficult life because they don't respond to treatment adequately and have very severe complications. And yeah, part of those actually can die. So that is the spectrum, and many, let's say, facets in between. And I think that's the reason why it's called a chronic disease. Answering your question again, what is the consequence for me? I think in the beginning, nobody can tell you for sure. Right now, there are some predictors for response of treatment. You can say a little bit, for example, age is a very good predictor. We know that patients who are older respond not that well as young patients. We know patients who it seems to be have a higher neutrophil count in the beginning, have a worse response, but it's very difficult actually to make a very detailed analysis and speculation about the future of every patient. So that's something which will only be shown in the future when you have been treated. And we know if you are treated by immunosuppressive treatment, you at least have full cyclosporin at least for 1 year, and then you are tapered for another several months. So it's not a quick win. It's not you are treated by 1 week and then the story is over. It takes years usually, and that's why it's so depressing for patients, because you have to come to the hospital or to the doctor so many times. You have to check on your treatment. You have to take your treatment every day. It's a daily reminder, and that's why the consequences are actually huge for the patient. And the same holds true for transplant. I mean, transplant patients are really regular surveillance, and they have a lot of other issues I can't cover here because they just that's too much. But that's the reason I think why it's called a chronic disease. Although I have to say, I don't want to give the hope up. See, I stay from the beginning. I stay positive with my patients, because I think it's really important to keep the head high. It's because the chances are good if you just belong to the sport and if you stick to it, and compliance of course is also very important. So I think it's important to stay on the bright side, but of course this is a difficult thing. Actually, it's a tough way.
Yeah, and I can confirm exactly what you were saying, because the doctors I was having were telling me The fact is that you have a family who is supporting you. You're in your head, you want to rescue from it. You have another disease you want to fight, and then you have fought against it, and you have rescued from it. So this is really the importance of thinking you're going to win. It's a battle, but you're going to win it. And this is linked to my next question, because that was a big one for me, because I had a 6-year-old daughter at that time. And it was, okay, is that disease, is there a risk that I transmit my disease to my daughter? And secondly, with those who have no kids, can I have a child? Can my spouse have a child? For men, when I say my spouse, it's for men. Can my lady, is there a risk I transmit it afterwards?
Yeah, I think we have to distinguish a little bit. Can you transmit it by genetics, or is your fertility influenced by the therapy, right? Mm-hmm. Totally different things, but I can say already patients with aplastic anemia can still get pregnant, right? They still have the chance to get children. I think that's a very important message. I think you will have to be cared at a center for that. It's important because actually pregnancy is a risk for relapse, but it's possible. That's the most important, I think, output. If you think about, can I transmit it to my offspring or to my children? I think the data on that is not clear. I actually don't know papers that show this association in a clear manner. I think what you can transmit, of course, is your ability, or your, let's say, the higher the genes that you might be predisposed easier to autoimmune disease. That's something which might be transferred to your children, okay? But I think it doesn't have to end in aplastic anemia, because we know that aplastic anemia also needs some kind of trigger to set up the immune system and then to attack the own cells. So it's a combination, right? It's the genes you have, but it's also the environment, most likely, which plays a role. So I think there's no clear association that you can actually transmit it to your children. There is a very clear association for the inherited bone marrow failures. So that's something I said in the beginning. I don't want to talk about too much because it's very, very difficult, so many syndromes. But in this setting, you can actually transfer it to your children. And that's the reason why it's so important nowadays. And I'm really a big believer on that we really have to understand and actually analyze in every patient with bone marrow failure, is there any chance that aplastic anemia is caused by an inherited disease? So when I actually looked at our cohort, I could see that actually many cases which were thought to be acquired aplastic anemia haven't been. There was an inherited trait, and we just didn't know back in the days. We didn't have the genetic testing. But I think they're now increasingly available in other countries, and of course it's always a matter of reimbursement and coverage by the insurance company. But as I just learned recently, also by a meeting in Paris, is that actually many centers do it now very nicely, and I think this is important because it has a huge influence not only on the patient and the treatment of the patient, but also on the family members.
Could I, Beatrice, just jump in and ask a question, because you just mentioned the fertility topic and said that it's not impaired with the treatment, but does this also go with patients that having a BMT?
Yes, because you can preserve, for example, eggs or sperms or something like that.
You'd have to do that.
Yes, you have to do that.
Yeah, that's just something I wanted to point out. Thank you.
Yeah.
And then Sylvia asked a question. She wants to know if anyone has identified any predictors for a relapse.
Yes, I think you have to turn around a little bit. As I said, there are predictors for response. And that has also to do with relapse. It's more or less almost the same. And for that, we know that age plays a role hugely. And it seems to be, but that's very like early, like there's just really freshly data from the NIH that it seems to be that the neutrophil count it plays a role at the diagnosis. And it seems to be, of course, the genetic of your disease. So we know that some genetic lesions can be present in aplastic anemia, and those genetic lesions can show an evolution over time. And we call this clonal evolution, and that can cause a form of transformation of the disease. For example, it's not then a relapse; it's a transformation. So you can actually be affected then by leukemia or myelodysplastic syndrome. PNH is also a form of clonal evolution, but it's a benign clonal evolution, although the disease is not benign. But it has a genetic background because you have this clone, which is linked to one mutation, PIG-A, and this clone gets bigger, which we see in some patients with aplastic anemia. Yeah. And
I am quite happy today because I totally recovered from the disease that I had 10 years ago, and today can work and can live again, I would say, even if I have not stopped living, but I can do whatever I want nearly. And then I have a question because I have already rarely been told that I was in remission, but I was not cured from the disease. So what is the difference in between those two? And are there special risks for me only being in remission?
Yes. So that's a very important point. So we have so-called remission criteria for aplastic anemia. There are different depending on which society you believe, but if you stick to the NIH, for example, criteria of remission, you only have a complete remission if you have, or you have a complete remission if you have platelets over 100, if you have neutrophils over 1 giga per liter, and if you have a hemoglobin over 100 or 10, depends on your what you use at your hospital. And as you can see, those values are not normal. So maybe you're not familiar with those numbers, but usually the platelet count is between 150 and 450. So if you have 100 platelets, you still have a low platelet count. So if you have 1 giga neutrophils, it's still decreased in comparison to normal counts, because you would have a higher count, which is called normal. And then hemoglobin usually also, depending if you're female or male, but the cutoff is usually 140. Okay, let's say it by that. So if you have a complete remission, your blood count, if you look at a lab paper, will still look pathological, right? Because you still have a thrombocytopenia maybe, or you still have a neutropenia, or still have anemia. You doesn't necessarily need to have that. You can have even higher numbers, that's possible, but per definition, you're in complete remission if you've achieved those counts. And still you have the disease, right? You can see it because the counts are still a little bit decreased in comparison to what is called normal. So you know that there's still an autoimmune effect going on. You still know that there's some T cells which might attack your blood cells. But you're happy with that. Why are you happy with that as a physician? And that's something there are many discussions with my patients, because my patient, at least my center, I don't know where somewhere else, but my patient want to have normal blood counts, They don't want to have platelets between 100 and 150 or something like that. They want to have platelets on normal. And I always tell them, yeah, I understand, but actually for your life quality, platelets don't have to be higher than 100. It's the platelets are necessary for bleeding, and you usually don't have significant bleeding until like 50. So if you have 100 platelets, you don't have significant bleeding. Neutrophils is the same. If you have neutrophils over 1, usually you don't have a very high risk for infection. You still have a high risk for infections, but you don't have that high risk of infection than patients with severe aplastic anemia, which have much lower neutrophil counts. So you have neutrophil counts with 0 point something, right? And then you have the hemoglobin, where I think that's actually the most important parameter for the patients, personally, because if you have a hemoglobin of 100, which is complete remission, by definition, you most likely still have symptoms. Because with a hemoglobin of 100, many PNH patients know that by heart, right? You still have symptoms. There are those patients which will always tell we know everything is fine, but actually there are a lot of patients who still have symptoms with that value, but per paper you are called in complete remission. So I think that's something maybe which answers your question, that the disease is still active, but your blood count is reaching those values, and then by definition you are called complete remission.
Then I'm happy. I'm like your patient. I am above it. So now we can perhaps open questions, because there are many other patients and people. Perhaps they want to share with us, and they have some discussion that we can go with them.
Actually, Ulrike is asking, how high is the risk of developing MDS or leukemia? Very good question.
Yes, very good question. And maybe those numbers will change because our treatment changes. So this is something which I'm going to say is not, I can tell you numbers now, but I'm not sure if they hold true for the future. But for now, what we know about the past, and several colleagues have looked at that, our group has looked at that, but also NIH, France, UK, you name it, and it's about 10 to 15%. And that was repeated in several studies. So, but we will have to see how this is true then, for example, for ThromboPAC or other agents in the future. And this is only, of course, I have to say, for patients who were treated by immunosuppressive treatment, and which means ATG and cyclosporin. This is not true for patients treated by transplant. So patients treated by transplant actually have a very, very low risk for AML and MDS, as a myelodysplastic syndrome. They, of course, have the huge risk for GVHD, so graft versus host disease, but not for so-called clonal evolution.
Thank you. Any more questions?
I would then have a last one, which is, what does it mean for me personally that the disease amnesia is considered as a rare disease?
Ooh, that's a difficult one.
You wanted one more for you.
I think the difficulty with rare diseases is that there are a lot of physicians who don't understand what the disease is about and what symptoms can evolve and what the treatment means and what consequences what consequences are going to affect the patients. We see this several times when patients tell me they go to their general practitioner and tell them, oh yeah, now I had this treatment, I have aplastic anemia, and the general practitioner is like, never heard of that before. What do I have to do now? So I think that's one side of the rare disease entity, that you, as a patient, it's very difficult actually to find your spot. So to know to whom to go, and to be treated well. There are some centers, of course, who have more experience on the disease, but you have to find that by a patient. That's not so easy, actually. We know now if you're patient advocacy groups, and I think that's a huge effort you have made, that you actually publish centers which are experienced for aplastic anemia, and you actually tell patients, oh, if they contact you, go this and there. I think that's very important for those rare diseases. But if you were a patient who was just in the beginning and you come to the doctor, you don't know if this doctor is experienced with your disease. You cannot really understand that. And I think that's a very difficult part on this disease, and always confuses, or maybe causes some kind of anxiety maybe as well, to be sure that you are on the safe side, and you have the right physician who understands your disease. And also, which has a huge effect, is that rare diseases, usually by center, you don't have that masses of patients. So even if you think you understand the pathology of the disease, and you know just because you learned it how to treat them, doesn't mean that you actually know all details of the disease. And it is really important, or I think it's really important, and I'm more a clinician actually than a researcher, is that you really have to see it. So I'm still very young. I'm approaching 40. I will admit that. So, and I'm happy that I'm at a center where we have a lot of aplastic anemia patients, but still I can say for sure I have not seen every complication, every form of aplastic anemia. So I still sometimes also battle this confusion. What is this now? How do we do this best? And I think that's why this initiative by the EuroBloodNet is a very important one, because we have to gather all the experts together and exchange. And it's really interesting to see that just now, with all the COVID stuff we have, this virtual thing goes up, of course, and we can use virtual platforms to exchange. And actually now there are several exchange virtually with other experts. And for example, especially for the inherited disease, there are a lot of virtual tumor boards now in the US, but also in Germany. There's one I know of. Maybe there's in UK as well. I don't know. But there are actually bone marrow failure specific genetic tumor boards where you can present your cases, and all the experts from the country can actually tell their experience on that. And I think that's really important for rare disease, because if you have those one case which you haven't seen before, and another center actually had such case, and you can learn from that. And that's also very important. And it's great that actually COVID did a huge step on that for all the patients. They can profit from that, right?
Unfortunately, we probably would have to say that on those tumor boards or those virtual options, mostly the specialists take part and not the people that don't have the wished experience. So,
what do you mean with wish to experience?
Well, the hematologist from a smaller town in the rural area, he will probably not take part in this, and will probably in his life has 2 patients, but the patients don't know that, and that's the problem.
Yeah, that's true. That's definitely a disadvantage, but I still think, for example, for some of those virtual tumor boards actually would be open to everyone, but it's just not known, and that's the problem, right? That's yeah. So maybe patients actually don't have the chance to be presented there. Mm-hmm. Yeah.
And then to Isabelle's question, I would like to add also the part that goes beyond the medical care, because a lot of problems arise for patients that, like in administrative areas, like the ministries, just don't understand what kind of disease this is, and they will think it's just anemia and will, for example, not give you the social care that you would need, or the financial care you may could be able to ask for maybe. And that arises that just causes a lot of problems too. And also, I mean, the social problems in the families, in the social surroundings of the patient, because also there people think, oh, anemia doesn't sound that bad. And then you will say, well, it's still bad. And they don't really take it that serious. You probably have, I sometimes recommend patients to actually say it's something like chronic leukemia, just to get it over with, because it's, it's not a great difference. And I think it relieves you from having to justify how you feel.
Yeah, I definitely confirm that. That's a huge problem. I have so many patients where either family members or the workplace actually doesn't understand anything about the disease and has a huge expectancy how patients actually should come back and should be functional again and should be working again, and just don't understand what this means and what the disease is about. That's it. That's a huge part, definitely. Yes.
Yeah, that's a huge part, and it's why we have a webinar here about the fact that you're tired with such a disease, because this effect is somehow not known by people around the workplace. Okay, well, why is he so tired? Why is he taking days off? Why? All this is linked to that. And the second thing to what you were saying is that personally, I have a little paper in my bag saying, in case of emergency, I have Aplastic Anemia, and please call the reference center. So that when the firemen take me in the street because I have an accident, I have a problem, but everybody knows. Oh, well, I try people to know it. Yeah, and give them the access to the doctors.
Yeah, it's a good point. I think that's something patients who attend now can take home, and also the point with the little cancer lie Pascale said is a good one. I think, yeah, even if it's not true, but I think it really is comparable. And sometimes patients or the environment doesn't understand it if you tell it the other way around. So I think that are some ideas how to cope with it better.
We have 2 more questions in the chat that I would like to ask. There's one: is there any movement toward a global registry for aplastic anemia?
Oh, I would love it. Unfortunately, no. This is a very, very difficult thing to set up. So we have this initiative, and Pascale, you know better than me, for PNH, but we don't have that for aplastic anemia, and that's a huge disadvantage for research because we have those local databases. The most prominent ones are, of course, the NIH in the US. Then you have Paris Reference Center. You have the UK, which does a nice job on that, better than other countries. But for example, I can tell you on Switzerland, no database for every patient with aplastic anemia. As I know from Germany, it's also not the case.
Yeah, in Germany, we're starting one now.
Yeah, that's true. But for now, right, there's nothing. And even then to combine this is almost impossible.
That's going to be.
I think there is a little bit of a chance. I still hope on that. And we saw this with PNH. Is the chance is there if you have money. And when do you have money? You have money if there is a new agent on the block, or a pharmaceutical company has a high interest to gather real-world data, and then they're going to finance stuff like that and push it.
So if a new medication comes around, you're saying?
Yeah, exactly. And that's what happened with PNH, and that's why we had this registry for PNH. But for example, for aplastic anemia, nothing like this is seen in the near future.
Yeah. You just mentioned real world data. Can you explain what that means?
So we have, so you have to differentiate on study data. So where patients were included into a trial, for example, they were included into a trial like a race trial where they got ATG and cyclosporin and ePAG, and all the data from the patients were included into a data bank, and you can then analyze the data. That's trial data. And then we have real world data, so meaning that the patient data is gathered from patients who were not included into a trial, or at least not mainly, and they're still followed up, and the data is gathered into a data bank. And that's actually very interesting. I think real world data is much more interesting than trial data, because it represents the usual setting. For a trial, there are always inclusion criteria, so some patients are not included. Mm-hmm. And that's why it doesn't reflect reality. Mm-hmm. And that's different with real world data. So you include patients, you have patients there who are getting treatments which they wouldn't get on a trial. And that's why it's much more important for the patient population, actually.
I agree. Then there's another question. Are there specific differences in the post-transplant treatment for aplastic anemia patients compared to blood cancer patients who were transplanted?
Yeah, there are actually huge differences. So actually, if you transplant a benign disease, which is aplastic anemia still is, although it has a malignant course, but if you transplant a benign disease, you always try to avoid graft versus host disease by any means. So you use a different conditioning regimen. So you just to explain that a little bit more for people who have never heard about transplant. Before you get a transplant, you get a form of chemotherapy to actually prepare the bone marrow to accept the cells from the donor, but also to remove your old blood cells, right? And with this conditioning regimen, you can tune it a little bit for, you want to have a little bit of graft versus host disease, because if you have graft versus host disease, you actually also have a so-called graft versus leukemia effect. So you also take the donor cells who then attack the leukemic cells. That's something you don't need in aplastic anemia. In aplastic anemia, you just want to remove the old cells and replace them with new cells, and you don't want anything else. You really want to avoid graft versus host disease. So you take a different conditioning regimen for aplastic anemia. And then afterwards, you also give immunosuppressive treatment for a longer period of time, because you really want to avoid graft versus host disease. So we, at least in our center, we give immunosuppressive treatment, full dosage for 1 year in aplastic anemia. For in comparison, for malignant disease, we would only do that for maybe a month to 3 months to 6 months, depending on the risk you have of the leukemia, but a maximum of 6 months. And then it depends a little bit of if you get graft versus host disease, but you actually taper this treatment much faster than you do it in aplastic anemia. And that has an influence on patients, because if you take cyclosporin full dosage for another year, of course you have a higher risk for infection, you have the side effects of cyclosporin, and yeah, so you have still for 1 year after transplant a lot of consultations and most likely effect on your life.
Thank you. Yes, the same patient is asking now 1 year before reducing. I know she's transplanted in a center where I know the procedures quite well. So I think they are reducing it much earlier then. And I would encourage her to ask not to do that, but to ask to take the cyclosporin a little bit longer and make sure they know what they're doing, because this is what they tend to forget. Because after transplant, that sometimes they just think this is a transplant, like any of them, and it's not. Most of the transplants are malign diseases, so that's what they do. But aplastic anemia is different, and it's so rare, so that's another problem. And most of the treating physicians don't have it on their mind when tapering or not tapering the cyclosporin. So yeah, Nina, ask there.
I do have to say, I mean, it really depends a little bit. That's why I don't want to intervene. It depends also on your condition regimen. It depends on your graft. What kind of graft did you get? Did you do the T-cell depletion? Whatever. There are so many things, you know, where you can tune transplantation. So it's difficult to say, but I think it's really important that you talk about for your physician on graft versus host prophylaxis, because that's the most important thing in aplastic anemia.
Yeah, you really want to do that, Nina. We can talk about that in private if you want. Just call me. Any more questions?
If there are no more questions, I would encourage all the patients who joined us today to go close to the associations who can help them on the administrative stuff, on the lawyers, legal stuffs, and on the life with the disease. It's why I joined an association, because I think it's important, because you are not alone. Just think about it. The logic of our association is just to tell you, it's perhaps a rare disease, it's perhaps a little one, but you're not the only one facing it, and we can help you in the way you want. We won't force you to do anything. We will just try and help you.
Yeah, that's a very important point as well. There I have a question for you guys from the patient advocacy groups. I know that not every country actually has a patient advocacy groups. So what do you recommend to patients who don't have that in their country?
Well, they need to have one patient that goes and drives it, kind of.
Yeah. Create it. I think that in many countries where when you have a few patients, some associations are created at one moment of time. If you are alone, unfortunately, it's not possible to create an association. But then what we try and do sometimes is that people come to see us, they speak the same language as we do. We don't know the country, we don't know the rules of the country, but we know a little bit reasons of the disease, how to get around the disease and stuff like that. So we can help on the medical, not the medical because we are not doctors, but on the explanation of the disease. And after that, we can try and see all the legal aspects if we can find some. Ladies, what do you think?
Well, I think the general problem also is that a lot of times patients with aplastic anemia and or PNH are either too sick to create anything, or they are too well to wanting to have anything to do with it. So, and we wish them all well, obviously, but when they're fine, they are not seen anymore. And the middle is quite small. So the patients that get involved and engage for a longer period of time are not many. And I don't know, maybe like I would say my engagement, I think I could probably think that this goes for other patient representatives and my age as well, is that in earlier days, like in the 90s, there was nothing. And it was quite easy to just start something. And then you just do something and go along with it. And I mean, that we try to encourage patients to just do some little things for our foundation and just create something in the frame of the foundation, and people do that. I just received something today where a patient collected tips for things that you could do yourself before, after, or while having a bone marrow transplant, which I think was very nice. And that's something that we can share with other patients too, and it's very helpful. And there's many other things that people can do, sometimes bigger things, sometimes smaller things. Just spreading the word is very important. Spreading our flyers, our leaflets, the postcards we have, anything that you can do to raise awareness makes always sense. And you don't have to do that organized. But I want to encourage all the patients to speak up for themselves. And if you do that with somebody else guiding you along and maybe has a bit more of a presentation in the public, that doesn't matter. You can do it any way you want. And, or maybe raise awareness for being a donor, for blood or bone marrow makes sense. You can do so many things. Even if you don't feel well, you don't have to do it on a regular basis. Just do something.
Yeah, definitely. I have sometimes the feeling that some patients actually don't engage too much because they don't want to be reminded of their disease. Yeah. I think that is a significant fraction of patients. Because I tried that actually for Switzerland, that Pascale, we tried to set up a patient organization. It was really difficult because a lot of patients told me, I asked, I feel now again good, and I don't want to be a reminder of the bad days, and I don't want to be approached by patients and seeing their symptoms again, and then it's so. I think that doesn't hold true for every patient. I think there are a lot of patients who still want to help and want to engage and want to be part of it, but I think some of them have those issues.
Well, that's why a lot of people think I'm crazy, because I remind myself constantly of my disease. But so, Maria, what would you say? Why do you do it?
It's a good question, Pascale. I think it's because I feel very grateful that when I was first diagnosed, I don't have aplastic anemia, but I have PNH. And I didn't know another patient. At this time, there was no medication. And if you just Google something, it's very scary not being able to talk to someone. You feel very alone. So that was the reason that I got involved with establishing a patient organization, because I knew how lonely it was to have a rare condition and just feel like you're the only person in the world potentially. This was quite a long time ago, before some of the patient organizations that exist now exist. But yeah, it was the desire for other people not to ever have to feel like that, and to have some kind of support. And no matter how great our consultants are and how fantastic they are and how much knowledge they have, they never know exactly what it's like to live with a condition, which is a perspective that you can only really have if you have what we call lived experience. So being able to share those kind of experiences with someone else is really, I mean, you can't give medical advice necessarily, but it's you're able to, you have some solidarity in a way, you're able to share, and I think that's really important.
Yeah, that's really important. And for example, I try this for leukemia patients, that I connect them to other leukemia patients, but we have enough at our center, so it's easy, right? But if you have such rare disease, you can necessarily connect patients at your center so easy. So I think that's why you guys are so important.
Yeah, I completely agree with what Maria said about the reason why she started that, because that was exactly why I got involved as well. And I mean, we, you know, Beatrice, that we try to connect patients in between Germany, Austria, and Switzerland, and connect them. And we do that along with the Aplastic Anemia and PNH association. And I think it works better every year. I think it, you know, there's more and more patients that do want to get involved. And I feel I connect patients that actually develop a friendship sometimes, which is very nice to see. And maybe that evolves even more. Any other comments or questions? Or there's a question I'm seeing from Katarina. Oh no, yeah. She's just saying 100% underline what Maria said. When I was diagnosed, there was barely any information. My treating center at the time did not have much experience with the disease. And it might also be helpful for other patients to also have role models, yes, in a way where things turned out relatively well. Yes, agree, Kati.
I have maybe one question for you guys. Maybe that's my final question, is I'm very interested on those symptoms which are not classically described. And for me, it's difficult because I don't want to overwhelm patients, you know, sending out questionnaires and reminding them of their disease or bothering them too much. What do you think? Is that something? I mean, I guess there are some patients who will like it and some patients who won't like it, but I think it's important. What is your opinion on that topic?
Well, I just discussed with Dr. Panzer that we actually take the QLQ 54 that you presented earlier on our website, so that people can download it and use it for their own use or for preparing for an appointment at the center to present their symptoms, and maybe also collect an idea of if they get better or worse in some things. So maybe just ask patients about it directly, the ones that you want to ask about it, how they feel. And if I think most patients like to be asked, because a lot of those symptoms are not assessed usually, meaning they're not talked about frequently also. And I think it would help patients to talk about it and also see, while they're being asked for, that they are part of the disease and it's nothing that they imagine or are just being very sensitive or something. So yes, I would probably just ask.
Yeah, I would agree with that, because it's similar in PNH. So when you go to an appointment, your doctors will ask you about the classical symptoms, but unless you're asked about something, you're not necessarily going to come forward and say, but there's this other thing that I really think is linked. But as a patient, you just know yourself. And I think sometimes if the doctor hasn't asked you, you feel a bit silly, like, oh no, it can't, that's not obviously related because nobody's asked me about it. So I think a question along the lines of, is there anything else that you're experiencing that you think might be linked to your aplastic anemia? And then if they tell you something that is or isn't related, I think there is no way of knowing. And really that's real world evidence, isn't it? Collected in its, you know, at its best, is asking people and then collecting it all. And some of it might be linked and some of it might not, but we don't know enough to know really. Yeah. And we've just had a paper or a poster or a piece of research done in 3 countries, in the UK, Spain and France. And it was just presented at, I think, the conference you've just been at, Beatrice. And it was done in an ethnographic study, which is where researchers go and spend time with with the person they're researching sort of in their home and just watching them and talking to them and their family and friends. And this is exactly what it showed. It showed that patients think that there's a number of other symptoms that are related to PNH in this case, but because their doctor doesn't ask them about it, you know, in consultations, they don't feel like they can say them, or if they tell them, they feel dismissed. So there's a real need, I think, to allow patients to tell you what they think is relevant, because, you know, I think that it could potentially be relevant, and it's all knowledge gathering for future insights into these diseases.
Yeah, it's great to hear that. I mean, I always thought that in some kind of way, but you know, there's sometimes a slim line in between. And I can just tell you for my transplant patients, we do that at least every year once. They get like a huge questionnaire, and it's sent out by post before they have the consultation. And you know what? I would say by heart, like about 90% of patients fill this out. And it has like, I would say 6 pages from the beginning to the bottom and very detailed, but it's very interesting. And by that, it's also for us easier, right? To understand where the problems are right now, and to get information we wouldn't have to ask actually. So yes, so I think it's a great initiative actually to put this questionnaire up on the website. Yeah. And I can only encourage patients who are online to use this questionnaire then, and to fill it out and to bring it to their next consultation and show it to their physician. Because actually, as a physician, it's much easier if you have this and you look at it and you know, there's the problem. Now I have to dig deeper there. So I think if it's so easily available, thank you very much for Pascale and of course Jens Panse, who initiated this together with you guys. I think it's great if this can be used, and yeah, maybe other countries can also do that, because I think it's published in an English version. So I think even other
any language there is basically, I think so. It's I think it's in 2 different Chinese languages. It's in all kinds of languages. So it's if any of the participants here would like to see it, they can contact me by email, and I can send it.
Yeah, and I think it's very important to talk about symptoms that are not the medical ones, that are not well known. And because sometimes people think, okay, I've got that, but that's not important because the doctor doesn't talk to me about it. So it's something different. I'm different from the other ones because I have that symptom. Perhaps it's linked to the disease, but I don't know how, and I can't explain how. So it's really a great thing to be able, and for the patients, to be able to have to say, okay, I talked about that with my doctor. For them, it's something important because then the symptom is recognized.
So I think I must jump into the conversation with the not very comfortable role of closing this impressive session. And I'm really wordless, and I'm really impressed because it has been so nice to hear all of you. I've learned so much about aplastic anemia, about patients' association roles, about also personal informative key messages from patients. And I really want to thank all of you. It has been really impressive. Sorry, I'm repeating myself. I'm repeating the words, but I'm really overwhelmed by this great session. So thank you very much.